my name is Julie Lees, and it's an honor to be here today. As Jorge has mentioned, I used to work for Foundation House, which is this company to start, and that's where my passion in researching about sleep and trauma started. So glad to be here so that I can share the findings and also other research around sleep and trauma to all of you, the clinicians that work directly with the population. So the hope, the objective for today, it's really, give you the summary of all the literature review. Honestly, I feel like I can cover everything in today's session because there are really not many out there. And also to present the prevalence estimate of sleep disturbance worldwide and also in Australia. And to also talk about some of the psychosocial and demographic factors that I've known associated with greater sleep disturbance. And I would like to share with you some of the conceptual models that kind of combined, what it meant by the, trauma exposure, post-migration stress, sleep symptoms, and mental health symptoms. And lastly, to give you some review about available treatment, but also so that there may not be a lot out there. That's why more research is required in this field, because there's really only one RCT out there. I just want to let you know so that you don't have your hopes too high in terms of treatment, but it's also to increase the awareness that we need more research in this area. Okay. So since I will be presenting the data, I did my latest review, because every year it changes, right? I remember I was presenting last year around this time, and the number of people who are forcibly displaced worldwide were 80 million. And now, of course, with Ukraine-Russia conflict, it has gone up to 103 million. And again, with the latest meta-analysis and systematic review published this year, this is the prevalence of the mental health that's commonly found in refugee asylum seekers. For PTSD is 31%, depression 25%, anxiety 14%. And this number are a lot higher than, the general population out there. And from this systematic review, they found that the factors associated with the increased prevalence of mental health are pre-migration, which is the intensity of the conflict, post-migration, where they're located, if the host country is from low income or high income country, it impacts how well, their mental health is. The other one that's known from this meta-analysis is that the characteristic of the migrant population is if they are young, when they move here at the very young age, then their mental health is actually worsened. As you can see, all these factors out there, not many of them is something that is modifiable, right? So this is when I start to talk about why do we need to talk about sleep. And I can already see a few things in the chat group today that everyone do recognize that sleep is such an important topic, which I agree. And to my surprise, when I went to study, decided to go to my PhD in 2017, there was so little out there that look into sleep in refugee population. It's so little. The thing is, sleep disturbance is a recognized hallmark symptom of PTSD. It's almost one of the special hallmark which is the trauma nightmare, right? And we know that untreated sleep have so much negative impact on health. To name a few, obesity, diabetes, cardiovascular disease, stroke, so many out there. You can read all those reviews in those references that I left out there. And so when we look into sleep disturbance, the prevalence from the systematic review that published in 2020 shows is 39% to 99%. When I started doing the research in the area in 2017, we don't have that number. So I ran a study using the data from Foundation House. From that data, it shows that 75.5% of asylum seeker refugee in Australia, in Victoria, actually reported moderate to severe sleep disturbance. Those were the number. And from my own studies too, 42% of non-treatment seeking refugee, meaning the refugee in the community, actually experience chronic sleep disturbance when I follow up 12 months later. And it has a direct and indirect impact also on their mental health, meaning how well they sleep, 12 months before can predict how good or how bad their mental health is 12 months later. Why we're talking about sleep, it's also because sleep disturbance is something that's more definable and it's a very treatable symptoms, right? That's why we need to start having more research and talking about sleep disturbance. And addressing in a lot of the non-refugee sample studies, in studies with veterans, people who, victims of sexual abuse, there's so many data out there that shows that addressing the sleep disturbance can actually lead to improvement in PTSD, the daytime PTSD syndrome, which is amazing. The thing is, sorry, I forgot to talk about why I'm using the term sleep disturbance rather than insomnia, because in the sleep literature, they're very specific how you define insomnia. And because with the lack of studies out there that look into sleep, we decided to, or the researcher around this area, to use the word sleep disturbance because it's to include people with poor sleep quality, quantity, and also those who just subjectively do not feel that their sleep was good. So it also includes insomnia. However, I know out there that there are other sleep disorder like sleep apnea, that is not, those are more specialized. So in sleep disturbance, it's really about insomnia and people who have difficulty going to sleep and staying asleep, right? So in trauma literature, that within the non-refugee population, they found that there's such a high comorbidity between sleep disturbance and PTSD, which is not surprising. On the latest systematic review in 2020, it shows that there's 70 to 90% of patients with PTSD also report of, difficulty falling asleep, staying asleep. That's really high, right? And many studies have also shown that people who have sleep disturbance before the traumatic event or during and short after the traumatic event, they actually have a lot of way more high risk to develop PTSD as compared to those people who have no sleep issue, and then after traumatic event, when they measure the PTSD level, they're actually a lot lower. So and then there's also many studies shows that sleep disturbance exacerbate existing PTSD symptoms and increase the level of distress and dysfunction. In fact, in many studies also show that out of all the PTSD symptoms, sleep disturbance is one of the most sought after for treatment, and also the most distressing symptoms of all is sleep disturbance. That is something also I observe in my own clinical practice. As Jorge mentioned in my introduction, so I remember in Foundation House, with the very bad torture history or what they went through, I was so ready to do EMDR with them, very specific evidence-based treatment, but they actually want help with the sleep, like so many of those clients. So yeah, that makes sense to me. And in the non-refugee population studies, again, they show that when you actually treat the sleep, not the PTSD symptom, if you treat the sleep, they have shown that it actually alleviates the PTSD symptom, even accelerate the recovery, all right? And from all this, I hope that you can see that sleep disturbing PTSD is not just, one of the symptoms of PTSD or the secondary symptom of PTSD. There's something that's actually more on the bidirectional relationship. However, not many researchers out there have actually created like the model, conceptual model. There's a few being proposed, but definitely there's no researcher out there that kind of like offer a conceptual model in the refugees field, in the sleep literature. So in the sleep literature, their understanding about the relationship between trauma and sleep is that, people in the aftermath of trauma, for example, car accident, sexual abuse, they actually start to have fear of going to sleep, fear of nightmare. They just feel vulnerable when they sleep. They don't feel safe. And so they talk about how because of trauma, it created a lot of anxiety on the bed. That's why they start to develop sleep disturbance. The other way around also, where people think that, poor sleep quality after a traumatic incident, what happens is they often have cognitive impairment and maladaptive coping mechanism. And all this have negative impact on the memory consolidation and inhibit the healthy processing, emotion processing. Thus, it maintains the PTSD symptoms. And others, meta-analysis study have shown that it actually, they show that sleep-specific treatment, such as cognitive behavior therapy for insomnia, imaginary rehearsal therapy, and exposure group and relaxation therapy, have shown that if patient with PTSD who also reported sleep issue receive this, they actually can enhance both the sleep quality and then also the PTSD symptoms. You can read this paper. It's a really good paper. So this was from the sleep field, the trauma field. So what's out there in terms of sleep and trauma within the refugee field? It's, again, this study been published in 2020, so it's way after I completed my study, which is really cool to know that they can actually have a systematic review because there's enough number of papers. So the prevalence shows that internationally, there's about 39 to 99% of refugees who are exposed to trauma actually reported sleep difficulty. The 99% is very high, but it's come from one paper that actually based on one question. So I think I'll just, not take that number as a whole, but I think it's somewhere in between. And so from that systematic review, they also found that the sleep disturbance are mostly predicted by the past war experience. And the most frequent mental health disorder associated with a sleep disorder or insomnia is PTSD. Again, as you can feel in this presentation, that there's something to do, this link, a very strong link between PTSD and sleep. And so sleep disturbance in refugee population are more correlated with their mental health, especially PTSD, than a psychosocial problem. These are, like I said, this is almost like a review for all the important papers out there that have looked into sleep and mental health in refugee population. So we have Montgomery that study young people. So these are in Denmark, study in Denmark. So they found that 34% of the young people actually have significant sleep disturbance. Okay, and then the other studies in Finland, they show that so they did a pair match study where they pair the Somaliland refugee and the Finnish native based on the age, gender, and some of the background. So they found that the Somali participants definitely have a lot higher mental health issue and sleep difficulties than the Finnish native. Yeah, and then so Sandel, Dr. Sandel, I've met her a couple of times. She's almost like someone I inspired, but also my nemesis because we started our study around the same time. Anyway, so she's great. So Dr. Sandel and her team, they're from Denmark. Again, they investigated. They tried to study, of course, for any research, you need to have prevalence. So with that one question, the prevalence that they published is that 99% of the participants who suffer from PTSD also reported sleep difficulty and recurrent nightmares. And Dr. Sandel also later on in 2021 published another paper that shows it's a longitudinal study. So it shows that the good sleep quality at baseline can actually improve the sleep quality and improve sleep quality in terms of treatment. It can predict the PTSD treatment response, later on, which is what the trauma literature and sleep literature have been talking about. So she's getting somewhere with her data. I'm looking at times. I feel like I'm rushing. So as you can see, these are all the data coming from Denmark, Finnish is all overseas. And also these are all data from participants who are help seeking, meaning they are going into, like Dr. Sandel, she's working from a place that's very similar to STARTS and Foundation House. So very, very similar system. So when I do my PhD, I wanted to understand what's the relationship between sleep, mental health, especially PTSD, and also migration stress, because I feel migration stress, it's one of the important factors that, predict the current mental health in refugees and asylum seekers. So I really want to know what's the status of that in the refugee in Australia, and also for clients who are in the community, meaning not treatment seeking, but also in the treatment seeking. So again, this started in 2017. So at the time, there was no prevalence. So I need to establish the prevalence. So my study 1 is really about prevalence. Study 2, I would like to find out the predictor of sleep disturbance, and also just to start to come up with like a conceptual model, because that's what's lacking out there. And in study 3, I follow the refugee from the community, 12 months, just to understand how many of them actually have chronic sleep problem. And yeah, so let's go ahead to look into the data. Because it's my study, I'm a bit biased, so I'm going to slow down a little bit. No, actually, I'm slowing it down because I feel like this data may be closer to home. I can imagine all of the refugees that you're seeing up there maybe from the similar cohort. So for the first paper on the prevalence, I used existing data from Foundation House. So for the client, the data from October 2014 to May 2017, I gathered 2,700 sample, and that is including children, adult, asylum seeker refugees. Okay. So this data is from the initial intake that usually take about 2 to 3 sessions. So the severity rating, absent, mild, moderate, severe, it's a very basic data. Yeah. So there's no like questionnaire. It's really based on the minimal data requirement that we have to, as clinician, we need to write. So for this study, I only take the sleep disturbance, the major mental health, PTSD, anxiety, depression, and psychosocial issue, interpersonal difficulty, family dysfunction, and social isolation. So quickly from the data, so it's about 30% young people, 70% adults, almost 50-50 in terms of gender distribution. And the top 2 countries for that year from Iraq and Iran. And in terms of refugee asylum seeker split, it's about 60% refugee and 40% asylum seekers. So this is the data. Like I said, it's based on the severity of absent, mild, moderate, and severe in terms of the symptom severity. If you can see here, anxiety actually is the most reported, as you can see. So this is severe, moderate, mild. Only 7.5% of clients there say they have no anxiety. So anxiety is the first, the most reported symptoms. Sleep disturbance is the second most reported. But if you look in terms of the severity of the symptoms, sleep disturbance has the most severe, meaning the most reported, like that they found difficulty with. Okay. I know I'm running out of time. Just quickly to highlight, when we look in the correlation of sleep disturbance and mental health and psychosocial, there's very strong correlation. Like this side, this size, effect size is large. So I divided refugee asylum seekers, but you can see that the correlation between the mental health, all this, it's so high. For asylum seeker, it's the same. For psychosocial in the refugee area, it's about medium size, and this is small size. But mental health, psychosocial are so correlated with sleep disturbance. Right. So when I include all the variables together in terms of age, gender, migration status, what predicts the severity of sleep disturbance? When we put all together, we realize that migration status, being asylum seekers, mental health, family dysfunction, and interpersonal difficulty. These are what predicting the severity of the sleep disturbance. So in summary, the more individual reported severe sleep disturbance than any severe symptoms. Okay, sleep disturbance was the second most common concern, and severity of sleep disturbance was significantly associated with major mental health and psychosocial issues. So, which means we do need to look into treating or managing the psychosocial issues. Next, for study 2. So for study 2, I recruited 86 Syrian and Iraqi refugees from the community. So with this study design, what happened is, sorry, I didn't read the objective. It's really to study more about the association between sleep, mental health, and migration stress, and also to learn a bit more about the predictors of insomnia risk. So the study design is, I met them twice. The first time, I'm collecting their demographic and sleep diary. Sleep diary look like this. So this sleep diary is for 7 days. So I want to know whether they take nap, how long it took them to fall asleep, how many minutes, and also, how many minutes you're awake. Meaning you're still awake, but you're lying on the bed. So all this information will help me to get my sleep efficiency. So sleep efficiency in the sleep literature is a way to understand the quality of your sleep. How you measure it is that the total sleep time, let's say you're lying down on the bed, let's say 10 hours. Oh, sorry, the total sleep time meaning is the time that you actually fall asleep, and sleep opportunity is how many hours you're actually on the bed. So maybe your sleep time is 5 hours, but you're on the bed for 10. So your sleep efficiency is 50, which is really, really low, right? So this is what we use. Then we have actigraph. The picture here at the corner, left bottom corner, it's this actigraph. So actigraph will measure also the sleep waking up time. So this is for us to kind of, we compare with the sleep diary just to see how off or how close, right? And so at meeting 2, I collect the sleep diary and the actigraph, and then I give them the study questionnaire. For this population is a good 50-50 female male. More than half of them are married. Unfortunately, as we know, about 80% of them are unemployed. This is nothing surprising, but it's very sad to see. This is the education. The age average is about 45, standard deviation 16. So they're displaced. Most of them were displaced for about a year and a half before coming to Australia. And how long they've been resettled in Melbourne, it's about 20 months. Standard deviation is 10 months. So which means they've been around here for about a year and a half. It's considered quite a newly arrived, right? So what I measure is very simple, again, because I don't want to burden the participants. Of course, I need to know the pre-migration trauma exposure, the post-migration stress. The mental health is PTSD, anxiety, depression using Hopkins. For the sleep, I only have the pre-sleep arousal scale. Why I use pre-sleep arousal scale is because it's one of those things in the sleep literature that show that has a mediating factors to quality of sleep and mental health. And from personal experience and reading more, I just have the feeling that pre-sleep arousal is something that can explain quite a bit about why some of them can't sleep. So pre-sleep arousal have the cognition and also the body sensation. Anyway, moving forward. Insomnia severity scale index actually measure sleep quality, sleep quantity, and that's usually what in the sleep field that often being used to measure insomnia. And then sleep diary, again, to collect the sleep efficiency actigraph. So the data here, in the summary, these are a group of people who reported significant post-migration stress because the cutoff 65, this 8.9. The cutoff for PTSD is 18, this is 20. 1.7 meaning most of them have quite a number of PTSD symptoms, anxiety, depression as well. This cutoff 1.75. Pre-sleep arousal, there's no cutoff, just to let you know, it's not too high, it's 30, but the possible score is 16 to 80. Insomnia severity index, it's above 10, which is the cutoff. So this group of people do have some kind of sleep subjective reported sleep issues. Sleep efficiency from the sleep diary, it shows that they're actually doing quite okay. Because in the sleep field, how you consider someone have poor sleep efficiency if it's lower than 85%. And this group have about 86%. So they're considered quite okay. And the total hour of sleep is actually 7.5. Again, it's so it shows that the sleep is actually not too bad. All right. So for this study, how we categorize the sleep, people sleep. So for normal sleep, meaning the insomnia severity index and the sleep efficiency are good, meaning it's less than 10 for ISI and more than 85%. So they're normal sleepers. Moderate risk is when either the ISI is higher than 10 or sleep efficiency is lower than 85%. High risk meaning both ISI and sleep efficiency are really bad, right? So the data shows that it's about 1/3 in each, okay? So that I want to know, so what can predict the severity of insomnia? So when I use the normal sleeper as the reference, what come out, when I put all the variables in, length of resettlement, trauma exposure, post-migration stress, and pre-arousal are what predicting people, comparing to the normal sleep, what predicting people fall into the high-risk category. Okay, these 4. When we use the normal sleeper, what are predicting people having moderate risk is post-migration stress and pre-arousal. These 2, whereas for this one is how long they've been here and the severity of trauma exposure. These are, again, quite new in the field, and was quite exciting for me to bring it up. Then I really want to bring to the attention of people about the concept, bringing together the post-migration sleep and trauma exposure. So I tested the serial mediation model, and it actually stayed, meaning post-migration stress, we know that it mediates trauma exposure to PTSD syndrome. We know that. This is the first time that we actually shows sleep disturbance mediate trauma exposure to PTSD symptoms. And it's definitely the very first time that showed this serial mediation. Okay, I tried to flip this too. It doesn't work. So there's something about, yes, a lot of people were exposed to trauma, but it was due to the migration stress, and then something about sleep disturbance that can impact the PTSD symptoms, which is quite neat. So in my sleep diary, there's a component that collect what were you on your mind when you can't sleep, or when you wake up from your sleep. Using thematic analysis, we found there's 4 main categories. One is around negative cognition, emotion, trauma, physiological, somatic arousal, and post-migration stress. So from here, you can see that it's when they can't sleep is because the emotional state, they're just feeling really down, or they're feeling anxious. They keep thinking about the past, ruminating, worrying about the future. This is that part. And the area trauma is about they think about witnessing death. There's something, I think, is an intrusive memory. They think about the loss of belongings, war related, because around that also there started conflict in Syria. Physiological, somatic, biological, it's like they have indigestion, they have to go to the loo in the middle of the night, stuff like that. Fatigue, just tired. Naps, nightmare, pain, like chronic illnesses, or they're being sick. Post-migration is they talk about just adjusting. Can I make friends? Will I be able to get a good grade? So because we have is people who are above 18, so some of them have to go back to school and whatnot. So daily stress about how they're going to pick up the children, how to manage children, worrying about family overseas, of course, unemployment. So these are the 4. And I really hope that one day when we do run translated cognitive behavior therapy, we can use this kind of data to psycho-aid client, and also to use it to cognitively restructure, how to think about it differently. So in summary, about 66% of the non-treatment seeking Syrian Iraqi refugee are at risk of insomnia. The high number of trauma exposure, the length of resettlement, post-migration stress, and pre-sleep arousal were predictive of insomnia risk. Surprisingly, someone mental health is not the it's not the only one that predict insomnia risk, you know. So that's why it felt like there's something more that can mediate. Anyway, so also there's indirect association of trauma exposure to PTSD via post-migration stress and sleep disorder. So I guess the clinical implication is that there's a theory to support both migration stress and sleep can contribute to maintenance of the PTSD, anxiety, and depression. Okay, it's not either or, and it's the first time that we shows that, look, we have to take these two things seriously to improve the client's mental health. And also when assessing for insomnia, clinicians, I think there's something about pre-sleep arousal and resettlement stress that we need to focus on, not just on PTSD, anxiety, and depression. Study 3 is looking at, sorry, I keep looking down just to see how much time I have. This is a follow-up study, 12 months on. I was very interested to see how they are faring and also whether changes in sleep can mediate the relationship, or, you know, in terms of mental health. All right. So what happened here is that we only follow up with the Syrian refugees, and we kind of lost contact with the Iraqi counterparts. So 69 out of 75 Syrian refugees were follow up for study 2. The study is the same design, except I didn't use the actigraph anymore because it was mainly to make sure that they're consistent. So for this time 2, 45 female, 55 male, 67 of them are married, more or less the same, right? So the only changes, so no significant change, chronic medication counseling, is that there's increase of employment, which is great. But they're more or less the same study measure: trauma, post-migration stress, PTSD, anxiety, depression, pre-sleep arousal, insomnia, and sleep diary. So again, community sample, they are not treatment seeking. What happened here is that 12 months later, there's increase of migration stress. And this is quite consistent with the literature out there. The longer they stay, they resettle. Sometimes they have increased migration stress. You know, we talk about the honeymoon period. So when they first move, there's a bit of stress, but they feel good that they're settled. But as times goes by, they realize that, oh, things are not any better, or they start experiencing discrimination, or they can't find a job. That's when the migration stress level goes up. You know, nothing surprising, and it's significant between time 1 and time 2. For PTSD, it actually reduced. Okay, again, there's something about the longer they stay, I think they feel maybe safer. And again, this is consistent with the literature out there. Anxiety and depression also reduced, significant. Insomnia also improved, meaning this is number of people who meet the clinical cutoff. From 53, it went down to 40%. Good. Pre-sleep arousal.
Excuse me, Julie, we have just a couple of more minutes.
Sorry. Okay, sure, thank you. For pre-sleep arousal, there's actually no change. In summary, there's an increase in terms of migration stress, decreased mental health, insomnia, no change pre-sleep. So this is the data. So as you can see, at time 2, 50% of them become normal sleeper, okay, which is great. Let's look into you know, how it changes. So people from time 1 that say they're normal, they continue to be normal. 6 of them become worse. And at time 1, those people that say moderate, 12 of them stay moderate, 8 of them become better, 1 become worse. For people who have severe sleep difficulty, 9 of them stay high risk, 7 become better, and 6 become normal. So overall, everyone's getting better. However, 42% of these people actually have chronic sleep. Because I don't have much time, I'm just going to quickly look at this. So when we try to understand what can predict time to PTSD and time to anxiety depression, I put all that in. It was actually pre-sleep arousal. Pre-sleep arousal is considered the one thing that whether increase or decrease can predict mental health. So this is the study set that I mentioned. It's about the changes in migration stress to changes in PTSD. It actually can be mediated by the changes in pre-sleep arousal. Same thing with anxiety. So changes in migration stress to changes in terms of anxiety depression, whether they go up or down, it can be mediated by changes in pre-sleep arousal. I redo this big model and it stayed the same, meaning it's still valid. It's not a one-off from my initial studies, which there's something about this conceptual model that we need to start paying attention to. Yeah, this is the summary. So there's something about pre-sleep arousal that we need to start to pay attention. Yeah. In terms of sleep treatment, in 2017, they showed this 4, which is music therapy, clonidine, and prazosin. At that time, they can't really, because this number is so small that they actually can't recommend any of this treatment. At that time in 2017, Sandel and the team was doing that one and only RCT, adding pharmacological intervention and also a PTSD nightmare treatment. This is the studies that just came out in 2021. Unfortunately, there was, pre-post treatment, the imaginary rehearsal therapy only have changes on the level of functioning, but nothing else. The Mindserin, which is sedating antidepressant, also have no effect on all these measures, sleep quality, severe nightmare, PTSD, depression, quality of life. So they did not find IRT or Mindserin actually superior to the treatment as usual. The treatment as usual is quite good, I have to say. So it's ongoing counseling, physiotherapy, massage. So there's so many things. So they also noted that there's very low adherence, meaning there's a very high dropout for these trials. Yeah, I just want to say that from the systematic review that talk about sleep, they talk about how we need to start doing prediction, meaning we have to validate, translate the questionnaire, prevention, we have to talk more about sleep hygiene. The number 3 is personalized medical approach, which we haven't done, which is translating cognitive behavior therapy, in the refugee population. Why CBTI is because it's the first-line treatment to treat sleep disturbance. You can read the review. It shows it's more effective than medication, and some of the effect actually lasted more than 10 years, and it's time limited to 6 to 8. It's not just ongoing. And these are the components, and there's no time for this, and thank you. Thank you, everybody.